Our next speaker is Susan Manzi, who's a MD, M.P.H. She's chair of the Department of Medicine of West Pennsylvania Allegheny Health System and director of the Lupus Center of Excellence, and vice chair and professor of medicine at Temple University School of Medicine in Pittsburgh. She's received her MD degree at Pittsburgh, her master's in public health at Pittsburgh. She was an intern resident at Duke. She was a fellow at the University of Pittsburgh. She founded the Lupus Center of Excellence at the University of Pittsburgh School of Medicine. She has over 150 articles, reviews, and book chapters. And today she's going to discuss new therapies in lupus. Susan.
Good morning, and my thanks very much to David and the organizers for this invitation to speak to you today. So I am going to talk to you a little bit about new therapies or just therapies in lupus. And I designed this talk to be very practical, to provide you with what I consider pearls to take back to your practices across the board in how to manage patients with lupus. So I hope you find it to be such. These are my disclosures. So this is a patient of mine, and I use her as an example of where we're not where we need to be in terms of the treatment of this disease. This is Juliet, and yes, she did give me permission to use her photograph here, so there's no HIPAA compliance issue. And Juliet, I've taken care of her for many years. This was a picture of her, 18 years old, a student athlete in high school, had a scholarship to go to college for basketball, actually, and developed lupus right before she left to go to college. And unfortunately, Juliet is one of these young women who's had multitude of problems related to her lupus. She's had cutaneous issues, she's had lupus nephritis, antiphospholipid syndrome, is on chronic Coumadin therapy, has had serositis, and I could go on. And then all of the other ramifications of the treatments that we give, including avascular necrosis and multiple joint replacements. And I know you have this in your syllabus, but this is a picture of Juliet now. And I use this basically to say we need to do better. We just are not where we should be in the treatment of lupus, even though survival for this disease has improved. I always say 1950, I was born in the 50s, survival for lupus, 5 years was 50%. So flip of a coin, you would be alive in 5 years. We are much better now. Survival's about 80 to 90%, 10-year survival, but we cannot have patients that suffer the damage that they suffer without adequate control of the disease. And I will say that our rheumatoid arthritis colleagues are much further ahead than we are in lupus in at least controlling disease and preventing this type of damage. So we clearly have room to improve. So what am I going to talk about today? The first, I'm going to give you some historical perspective. It's always good to base where we are now with where we've been. I'm going to revisit some known therapies and hopefully provide you some tools and pearls about some of the treatments that are available to you now. I'm going to talk a little bit about some of the novel therapeutic agents in the pipeline and a little bit about beyond disease activity, because in many cases, and I'm sure you'll agree with this, you become the primary caregiver to a lot of your patients. At least they see you as such. And so I think we have to be thinking beyond just taking care of the active disease. So what about a historical perspective? Well, I love this quote. I use this all the time. This Dr. Hutchinson was a dermatologist in London, and in 1880, this was his remedy for treating lupus. We must improve the patient's state of nutrition with tonics, good food, bracing air, cod liver oil, and the judicious use of stimulants, arsenic. The specific for psoriasis may usually, with much advantages, be added. So no matter what I show you today, we're better. We're better off than where we were. So what's happened with lupus over the years? Well, in the 40s and 50s, the anti-malarials were really the drug of choice. And it was really by serendipity that we started using anti-malarials because it was noted in people being treated for a variety of conditions, and particularly malaria prevention, that joint pain got better and cutaneous rashes got better. And then in the 1950s, we all know the landmark discovery of corticosteroids by Professor Hench,